We are still learning what data will make success possible.
Data is only as good as the stories that you can tell with it.
That one patient stimulated a quality project that completely changed how we're doing practice.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. Today's topic is cranking the opportunity engine. We will focus on quality performance improvement, but not the same talking points that you've probably heard for years. We have a great panel today. So today's guest, we have Dr. Brad Hubbard, cardiologist at Trinity Health Michigan Heart, Amber Pawlikowski, Director of Client Services and Quality Improvement Analytics at Biome Analytics, Denise Busman, VP Care Transformation at MedAxiom, Joel Sauer, EVP Consulting at MedAxiom, and then also Stuart Jacobson, founder and CEO of Biome Analytics. Welcome to the podcast, everyone. Thanks so much for joining us.
Our pleasure.
Thank you.
Thank you.
Thank you.
Great. Glad to be here.
Well, I always love to tout your resumes. You guys have beautiful bios. So we do encourage our listeners, read their full bios in the episode notes if you want to learn more. But let's dive right into this topic. The first question, though, we do ask all our Heart Talk guests: why did you decide to get into healthcare? And did you have that aha moment, or what was that like for you? Amber, let's start with you.
Absolutely. So, healthcare is kind of the family business, so to speak. I had a lot of mentors growing up, and in my family as well. My mom's a nurse who I saw working in the healthcare field and had a ton of job satisfaction and, really a lot of drive and dedication to the field. So seeing that growing up really made me feel that that was a career that I wanted to pursue. And I am very happy with the choice that I made.
All right. I love it. Stuart, how about you?
Well, mine's a little bit more personal story. I encountered the healthcare world due to a disease, and fortunately, I was treated by one of my best friends, who's a cancer doc, and I watched him struggle trying to get data, insights into clinical practice. And so I am an entrepreneur, and I decided that this is a great opportunity for us to get started. And so we dove in and started to discover all the ways that we could help docs, and our mission is to help them improve the quality of their care. So that's how I got into it.
Wow, it's awesome to be able to have the resources to help. Is pretty amazing. So, Dr. Hubbard, how about you? Tell us about your aha moment.
Melanie, I wish I had an aha moment. I just my father worked at John Deere in a foundry, and never went to college. In fact, none of my parents had gone to college, and I knew that I wanted to be a doctor at a young age. I just worked hard. I went into a small hospital when I was in high school, and I told them I wanted to be a doctor someday. And they said, "Well, we have a job for you," and that was scrubbing floors at the hospital. And I was pretty determined after that summer that I was going to go to medical school. I was going into healthcare, and I wanted to be a doctor. But no, I've done it for 30 years, and it's been a phenomenal career, and very happy.
I love it. I love it. Sometimes it's what you don't want to do that leads you to what you do want to do. All right. So Denise, how about you? Tell us your aha moment.
Yeah, no, thanks. Well, like most decisions, it was probably a series of things that led me to healthcare as a whole. So I was always fascinated by anatomy and physiology. Ever since I got to dissect a frog and a baby pig in 6th grade, wanted to make sure the boys didn't have the upper hand and that I got to be right in there and pulling the pig apart, just like everybody else. I was not the girl that said, ooh. But I was always also interested in human behavior and how people respond and adapt to situations. And then I've always felt rewarded in teaching and helping people understand complex things and situations. So it's kind of that amalgam of things that led me to nursing, I think. And then within that, the variety of careers that are available as a nurse. You can be a teacher, a clinician, a facilitator. It's all of those things. So probably the aha moment was one of I can do so many things and speak to all of those things that bring me joy.
Wow, that's great. It's cool that you had that exposure at such a young age to lead you down that path. All right, Joel.
Well, my actual genesis into healthcare was mostly serendipity. I needed a job. I was working in a city that had a large university that graduated way too many people who were willing to work for low wages. And so I found a job in a software company that was developing at the time the very new microcomputer-based healthcare software. And that got me introduced into the hospital, where I met people who were leading those organizations, and I was instantly smitten. And I thought, that's what I want to be when I grow up. I want to be a healthcare leader. I couldn't think of a better place to be in terms of an industry. You're helping people at their hour of need. So that's where that came from.
Boom. And you're making a difference for sure. All right, let's delve into the topic. Stuart, you're up first. In a recent Business Wire article, you said that health systems are returning to pre-pandemic volumes, except now patients are presenting with advanced disease and treating them is more costly. That certainly is a conundrum. So can you tell us more about this thought?
Yeah, so during the pandemic, we saw the challenge that hospitals faced was to figure out who to treat because resources were scarce. As the pandemic moved into an endemic disease, I guess, we are seeing patients that were delayed presenting with more complicated conditions because their disease has advanced. At the same time, we're seeing hospitals suffering from acute staffing shortages. So the importance of driving high performance care, efficiency, and treating patients most effectively is really increased. And so that's what was a source of my comment in Business Wire.
Yeah, that makes sense. I mean, it's unfortunate that people didn't get the care that they needed. And now on the other side of this, it's just harder to get them into that better health area. Dr. Hubbard, let me bring you into this conversation as well. From your perspective as a physician leader, what are some of the major barriers to quality performance improvement that, clinicians face?
Yeah, Melanie, that's a great question. It's interesting. I've been doing quality work for 30 years. And in the 30 years I've been here, we went from having very little data to now we have a lot of data. But just having data and making sure that it's accurate is important. And so the first barrier, really, when you start doing quality work is getting good, accurate data. And I know there's been some talk already about that. And it's interesting, for the first 15, 20 years, I figured as a physician, I could analyze all this data. And Amber actually had worked with us for 5 years. And she was phenomenal as a quality excellence leader. But Amber really hit home to me the ability of working in a dyad relationship, of being able to do data analytics. It's really how you analyze the data and ensuring the accuracy of the data. So I think the first barrier is data. Two, then, is really the quality structure. You need to have a physician leader, somebody that's really passionate about the particular project, somebody with the skills to, number one, understand cardiovascular disease, two, the ability to do lean projects, but three, then being able to do some data analytics with that. So I think the data and the quality structure are important. Next one would be culture. You have to have the right culture within the healthcare system, within the hospital, and within the physicians. After culture, then I think comes looking at your return on investment. And this was some work that both Biome and MedAxiom did a few years ago at one of the MedAxiom meetings. So the return on investment is important because if you're bringing back $1 million to the institution, then you don't want to necessarily retire that. The work that Amber did in 2021 at our hospital, we saved $3.6 million. So it was important for our quality people for the hospital to understand what quality brings back.
Yeah, no, but it makes sense. Amber, let's bring in, your reputation. You have a strong reputation based on what Dr. Hubbard just said. You recently said that hospitals are data heavy, but information poor. So can you share a bit more about this perspective?
Absolutely. So, the notion of data rich but information poor has been around, in the business industry for quite a while and is, of course, very applicable to healthcare as well. The problem that we have, especially within healthcare systems and hospitals, isn't lack of data. It's really that there's not enough information. And of course, data is only as good as the stories that you can tell with it. Data in the absence of supporting context and, good visualization and analytic tools is really not what leaders need to make decisions. And I think that, to be information rich, the various data elements have to be validated, aggregated, summarized, creating sort of that common source of truth. And I think that that's what healthcare leaders need to make, actionable decisions. They have to have good data stories to be able to drive and improve the value of care.
Yeah, because sometimes it can be so overwhelming to have so much data that you don't process it and it doesn't really make sense to you in connecting all the dots. So
absolutely.
Well, that sounds like a good place to do a quick pause for a break. When we come back, MedAxiom experts Joel and Denise will share some industry secrets on cranking the opportunity engine. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back, everyone. So far, we have talked about the challenges to quality improvement. So now let's dive deeper into my favorite subject, solutions. So Denise will bring you in. In your recent blog on medaxiom.com/blog, you say it can take up to 17 years for only 14% of published evidence to translate into practice. What are the top 2 or maybe 3 things CV programs can do to speed up that process of translating science into actual practice?
That's a really great question, Melanie. And every time I hear that 17-year reference, I just stand amazed that it really does take that long. Really, the whole issue, I think, is so vexing to clinicians and operational leaders alike. And I think a lot of it is healthcare delivery is so incredibly complex. So that while you know what you should do, making it happen is a whole nother story. There was a paper that was published in JACC in 2017 where they reported on a science implementation work group that was funded by the National Heart, Lung, and Blood Institute. And a couple of the things they pointed out there that I referenced in my blog were interventional strategies of leadership and then involving stakeholders. So as you know, at MedAxiom, we're huge fans of Dyad Leadership. And that's where you have an engaged clinician like Dr. Hubbard paired with an operational expert, like perhaps he was at the time with Amber. And when you combine those two things, you get this synergistic equation where the clinical leader is bringing this clinical decision-making, credibility, and influence, and that augments the practical implementation knowledge, maybe the analytical knowledge of the operational leader. So together you have this tremendous increase in the likelihood of success. And then I think a second strategy is to make sure you involve stakeholders. And again, it's stakeholders that are both clinical and operational. So because they're so key in identifying workflows and implementation strategies that are going to transform what you've got for your current state into one that will bring greater value in the future. And once you do that, you've got a platform on which to build consensus with the other clinicians. So Dr. Hubbard can then bring that message to the other clinicians to say, hey, this is what we've got. Let's share some ownership here, the buy-in that you need to have, and understand what the everyday situation is of those workflows that will help inform the sort of strategy that we may need to take to make improvements. So I like to say many times, change that sticks is change that starts with the people it impacts. Taking their perspective into account when you design that new behavior or workflow so that it can actually become a reality and have greater likelihood of success. And then third, I think one of the things that we've already alluded to is understanding what to measure so you know how you're doing. So it's identifying those data elements, having good information behind what the numbers would say, so that you can really identify when you're making progress. You say, this is where we're currently at, this is how we're coming along, and here's the point at which we implemented a specific tactic or intervention to get us further along on our journey. So once you can understand the information, you can then choose the right things to measure to help you set your goals. And I think, as Dr. Hubbard mentioned, you need to have goals that are compelling and important for patients and clinicians, and making them achievable too, so you don't feel overwhelmed. If you take something and you say it's going to solve world peace right off the get-go, you're probably not going to get the engagement you need, because people will feel far too overwhelmed. So I think those are some of I would say, my top 3 that you'd want to aim for.
Yeah, I love that. I think we all want to be ambitious, but we need to be reasonable too.
Absolutely. It is. It's one of those things that it's easy to get and I'm one of those people, I get all geeked about the fact that we can do this, and I want to do everything all at once. But the other point with that is, if you try to do too many things at once, you don't necessarily know what it was that really created the secret sauce of success. So taking it one step at a time to allow yourself to reflect back on what the improvement was collaborated by is a helpful step.
Yeah, good point. Good point. So Joel, for years, the CV community focused on this quadruple aim of healthcare: lower cost, better outcomes, increased patient satisfaction, and improved provider well-being. As the data expert at MedAxiom, yeah, that's you, how can CV programs use analytics to make this well-meaning catchphrase a reality?
So 2 things. One, I'll say we're still on that journey, and I don't think we'll ever leave it. There is no such thing as healthcare without those 4 critical pillars that you just described. And what we have learned is volume is relatively easy, and I don't want to be crass, but it will sound that way. In the current environment, for the most part, all we have to do is ring the bell and we get paid. In that new world order, it's going to be a lot more challenging, because we really don't even understand yet the levers that will create success in the future. And what we need that we do not have or are still developing, and we can thank partners like Biome and others who are helping fill this void. We are still learning what data will make success possible. So data are absolutely critical in that journey, because you're marrying together what are currently very disparate worlds of finance, quality and outcomes, people in HR and payroll and things like that. And those systems historically have not talked very well. And now we're saying we need to make those talk. And so that's going to be a big challenge for the industry for a while now.
It's a different mindset for sure. Dr. Hubbard, from your perspective as a provider, how have your patients been impacted by your team's work with quality improvement? And if you do have a story, we'd love to hear it.
Sure. Yeah, I think, we had so much quality work going on during COVID. I mean, I remember there was a 50-year-old patient of mine came in March of 2020, right after we had got into COVID. She'd had a heart attack. She comes into the emergency room with chest pain, and our chest pain center had been closed. And so she came in, got a brief evaluation, and was discharged home because she did not want to stay in the hospital. So it raised now a conundrum. What were our traditional approach to patients who came in with chest pain is if they didn't have an acute heart attack, they'd go into our chest pain center. But now our chest pain center was closed. So we had to figure out very quickly what to do with this. So this 50-year-old patient of mine really raised an important question. We had done a project about 5 years before where we discharged patients with AFib. So we modeled a project after that based on this patient. And to our surprise, we found that close to 85 to 90% of these patients were showing up in our office 2 days after they were discharged from the ER. We weren't finding any deaths. But what we really found was that there was a huge decrease in the amount of test utilization. So we actually reduced testing by close to 70%. And so after a month, things were going well. We decided to look at data at 3 months. And now 2 years later, it's interesting that one patient stimulated a quality project that completely changed how we're doing practice. And so that moderate risk chest pain center patients, instead of being admitted, are discharged from the hospital. And Amber and I actually are in the process of writing this up. But then when you start talking about return on investment, what we showed from this was that we saved $1.8 million for the healthcare system. But I think our culture was very important in this. I think the return on investment was very important on this. And so I think this one patient really set up a great quality project, and it highlights a lot of the points we were making earlier on how you run a quality project, and it's been very successful.
Wow, that's great. I mean, and that's a perfect example of how data becomes information that stands the test of time, 2 years later, still implementing the same practice.
Yeah, absolutely.
Amber, now coming kind of full circle with today's episode title, Biome recently announced a new platform. It's called the Biome Opportunity Engine, which leverages advanced machine learning to automatically identify and prioritize clinical and financial performance opportunities with the greatest impact on outcomes. So tell us more, walk us through a high-level overview of how this new platform works.
Yeah, absolutely. I think as we walk through this, kind of overview today, you'll hear many of the elements that Dr. Hubbard and Denise mentioned, and how to approach improvement. And so what the Opportunity Engine does is it uses machine learning and a proven QI framework, mostly grounded in Lean Six Sigma, to create those actionable information insights around performance improvement. So the first piece of that work is using the Opportunity Engine, programs can identify and rank individual opportunities based on the area of focus. So for example, if a program is most interested in distance from the mean in terms of a quality outcome or looking at financial opportunities, national rankings, things like that we most frequently know that hospitals are focused on, they can customize those focus areas and identify measures with the most opportunity for improvement. And this really saves hundreds of hours sifting through those, individual outcome reports or PDFs, Excel documents that most of us in the hospital world are very familiar with utilizing. So this is a big time saver. And then when we think about the actual approach to improvement, we know that we have to make quality improvement manageable. So we can't just say something like improve PCI readmissions. And this is, I think, what Denise was definitely talking about as well. That's kind of too broad of an outcome measure, and it really needs to be sub-analyzed to truly make those strides towards improvement. So it's really critical to identify key cohorts, which, leading and lagging indicators, demographic variables, those procedural, physician, and patient characteristics that influence outcomes. And so it's important to consider all these areas when you're truly trying to address the root cause of an issue. Analyzing data in this granular way allows hospitals and health systems to, decrease the time that it takes to do these QI projects and also the resources that are required in an environment that we know is, really resource constrained right now. And one of the examples of talking about that PCI readmission analysis is that hospitals might have limited resources to say that they actually want to improve PCI readmissions. So what we can do is we can say, okay, knowing that there's limited resources and analyzing your hospital specific data, this is the specific procedural cohort that you might want to focus. So, a great example of this that just recently came up was, a hospital wanted to implement follow-up phone calls, but they knew that they had limited resources. So using that Opportunity Engine, we were able to say, it looks like the NSTEMI patient population has the biggest opportunity at your center. So this would be a great place to either pilot an intervention or focus strategies to have the biggest improvement opportunity. And so again, the opportunity engine uses machine learning to do all of these things and drastically decreases that time that's required to complete a quality improvement life cycle, and of course the resources to do so. So I think this platform is really revolutionizing the lift required to complete QI projects, and I think it'll definitely be a game changer for sure.
Cool. I know you only scratched the surface on that. So if you do want to learn more about this, it's biome.io, and we'll make sure we get that link in the episode notes so that you can learn a little bit more about what Amber was just talking about. All right. So I'm going to pose this to all the guests. And Joel, let me start with you. How do you envision CV quality improvement, will look in 10 years, given the advancements in AI and machine learning that we've discussed today?
Well, boy, that's a big question. And what we have discovered as human beings is we're really horrible at predicting the future. So I will say this, I think it's going to look completely different in ways that we probably can't even imagine right now. That tends to be the case. I'd like to use at least attributed to Bill Gates. I don't know if it's real or not, but that we tend to underestimate it tremendously in the long run. And I think that's what we're going to see with AI's intrusion or improvement of healthcare when we look out on a timeline like 10 years. I've also learned as I get old that 10 years felt like a long time when I was 30. It feels like a lot less time now as I advance in my career. And boy, that it will go by quickly. But I think the short answer is we will use quality data in a very real and meaningful way, which we don't do as well today. And I think that's going to be a big boon for patients, which is what this is all about, and for guiding our decision-making as healthcare organizations.
Perfect. Denise, what do you think about that topic?
Yeah, that's a fascinating question. I will be interested to see what that tipping point is, because I don't think it's going to be 10 years. I think it will be sooner. I think we're just on the cusp of understanding the kind of data and how actionable it is. And I think we will be driven by the need for value in healthcare, so that little extra push that maybe we've gotten from the pandemic and some other features when it comes to paying for healthcare may push us there a bit sooner. I'd like to think that we will have that we'll have more of a laser focus, because we'll have actionable, targeted information instead of some sort of a buckshot approach where you just hope that maybe I make a difference by trying a bunch of things. So by working smarter and not harder, and having the information to drive us towards that goal, I think that's what AI will help us to do, is to just really be very smart about the work that we do.
Dr. Hubbard, what do you think? And we can say 5 years, not 10, if you want to look at it, because I do think, to Denise's point, things happen a lot faster than we can anticipate.
Yeah, and I would reiterate some of the things that Denise was saying, because, and what Joel was talking about as well. I think the issue of costs are huge. And we started to see this with Obamacare, where we thought we were going into bundled payments, and that got put on hold. But what I find myself as a physician leader now is I'm caught in this dichotomy between the healthcare system. I sit on our system's CV service line and our own hospital. And the CEO of our healthcare system has told me, said we need to reduce costs as we're negotiating with insurance companies. But the president or CEO of our own particular mission hospital is still reimbursed or still incentivized for volume, as Joel was talking about. And so I think within 5 years, we all have to be incentivized on the same thing. And we just can't continue our healthcare system with the same costs. So I think the big shift you're going to see, Melanie, is to really start to reducing costs, as Joel said. And I think that you're going to see the healthcare systems are going to push this down to the ministry level. But two is, I think that things like this opportunity engine with Biome, but what as Denise was talking about, the idea now is you pick a project, you do the project, and you see what the ROI is. And I think, trying to put the horse before the cart and say, look, what are your ROI opportunities? You just don't have the time or the resources to do, as Denise said, the buckshot. You need to know what your opportunities are. And I think that's where opportunities like Biome. And the third thing is, I think, the ability to do more data analytics, as I was talking about, you need to make sure that you understand your data, that you've got accurate data. And so I think data analytics and accurate data is going to be the real key in the next 5 years. And it's very exciting, I think, where things are going.
Yeah, I think so. Amber, what about you? 5, 10 years, what do you think this will look like?
Yeah, I mean, I think that's a great question. And, I think there's a lot of question marks still, in the air in terms of how we make this, really applicable to healthcare. One of the things that I think is the biggest opportunity, and Denise mentioned this a little bit earlier, is that we have a lot of great evidence-based care models and we have a lot of great, data, but it's really hard to implement some of those in the hospital level and understand the impact that it might have on your specific community impact. So how does that, the model or the application of evidence-based practice impact the patients in your health system? And I think AI has the ability to really help with that, because instead of somebody manually sitting down and spending all of their time analyzing data, there's a lot of opportunity within the AI world to help take those models and those interventions and understand how they impact population health within individual communities. And I really think that's the key into starting to deliver better care at a higher value, and then also addressing some of those social determinants of health too, which we know is really incredibly important. So I think a lot of exciting work to come, and I'm definitely, really excited to be a part of the ride and see, how this plays out.
Yeah, I love that. It helps you hit all the pockets, and all the areas that need addressing at this point. All right, Dr. Brad Hubbard, Amber Pawlikowski, Stuart Jacobson, Joel Sauer, and Denise Busman. Thank you all so much for sharing your time, your stories, your expertise today on MedAxiom HeartTalk.
Thank you.
I appreciate you all.
Thank you.
And that is it for this episode. If you liked it, please tell your colleagues and let them know that they too can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you would like to send us a note directly, even suggest the topic, email us at hearttalk@medaxiom.com. Thank you so much for listening. Have a great one.